So we come to the end of the Brainmets workshop, and the last topic is Leptomeningeal Carcinomatosis. I'm Professor Vijay Patil, and I work at the Department of Medical Oncology at Tata Memorial Hospital. The issue is, till a few years back, we never used to actually much give essence to this topic because it was considered like a death sentence to the patient. Hardly we used to check the CSF also. This topic has got a, what you could say, a new lease of life because of development of driver mutations, where now we see that this is a site of failure in this patient. So what is it actually? So when you look at this diagram, what you see is that we're talking about this space here, which you have blood vessels and CSF, and you would have disease in this leptomeningeal space that the cancer cells start blocking the exit of the CSF. And because those cancer cells are in the CSF and they are blocking the exit of the CSF, most of the symptoms of leptomeningeal disease, constitutional symptoms, will be of raised ICP, which would be headache, vomiting. Another things which can happen is you could also have such outpouchings where the nerves are coming out. And hence, these cancer cells can also give rise to craniopathies. It can be central cranial nerves or peripheral. Okay. Sometimes these may be also associated with brain parenchymal mets. It said that patients who have brain parenchymal mets, the chances of them developing a leptomeningeal mets are higher. This can also be associated with extradural mets. But remember, for the definition of leptomeningeal mets, to say that a patient has leptomeningeal mets, you should have this involvement of the pia with cancer cells. If the involvement of the pia is not there with cancer cells, it cannot be defined as leptomeningeal mets. So if you're clear with that point, we'll move on to the next. Now what you see here is, this is the way normally when you are supposed to give a talk on any topic, here we do advanced PubMed search, and you could see that the number of articles which came are very few, especially and especially most of the articles have come after 2017 and 2021, and the relevant number of articles were only 10. I did this search again this year. This article number has now gone up to 110, which means that this field is quite expanding fast. So when do you suspect that the patient may have leptomeningeal mets? For you to diagnose leptomeningeal mets, you need to suspect it. Tumors like lung cancer, especially driver mutated lung cancer, tumor like breast carcinomas, especially the HER2 positive, or melanomas, have a propensity for leptomeningeal dissemination. As I told you, could have features of raised ICP, or you could have features of spinal nerve deficits. The interesting thing is that you may have features in brain imaging and in spinal cord imaging. So what are the features which you should be looking in brain imaging? Normally, whenever you look at there are two MRI images which actually help you out with leptomeningeal mets. One is T1 contrast. Now, in normal T1, the CSF will be black. T1 contrast, you are given a gadolinium contrast, so the vessels would get highlighted. We are looking for any pial enhancement. Normally what happens is, if you have this as a brain, the enhancement normally goes only 1/3. So if you draw from the cortex a line inside, it goes only 1/3. If an enhancement is going more than 1/3, it can be two things. One, that either the contrast was given too rapidly or over contrast was given. That possibility always needs to be kept in the mind. Or second, the patient has leptomeningeal spread. Second is, you look at enhancements which are supposed to be there in the ventricles. If you are seeing constant enhancements in the ventricles which are not following any known vascular pattern, then you suspect that patient has leptomeningeal enhancement. When you look at spinal cord, it becomes more difficult as physicians for us to interpret the axial imaging of the spine, but the same principle, you're looking at the spinal space if any enhancement is there. Now, whatever findings you see in T1 contrast, you need to verify the finding in an FSPGR. For the FSPGR is fat saturated. So it's a special type of MRI in which you see whether the enhancements which you saw in the T1 contrast are those also seen in FSPGR imaging. If they are seen, which means that the patient likely has leptomeningeal mets. Now, when you talk about diagnosing, let's say that you suspected leptomeningeal mets, you obviously would get an imaging. You will obviously would get a CSF done for the patient. If the you would look for features of race ICP and there's no papilloedema, then only would do a CSF for this patient. Uh, the sensitivity of CSF is like it keeps on increasing till 3 CSFs. After doing, if like 1 is negative, you repeat 1, you repeat 3. After 3, if you do 4, 5, the studies have shown that the sensitivity doesn't increase. So normally in clinical practice, most of the people will do 1 or 2, but there's no point in going above 3 CSF. You divide them into as how do you say that it is leptomeningeal as confirmed leptomeningeal mets, probable leptomeningeal mets, possible leptomeningeal mets, and there is no lack of evidence of leptomeningeal mets. And this is the EANO classification. This will be the classification you would be seeing, would be used in most of the studies of leptomeningeal carcinomatosis. So let's see what is required to put this patient into this way. Type 1 leptomeningeal diagnostic criteria, there is a positive CSF cytology. So there's no doubt that the patient doesn't have leptomeningeal mets, and hence you would say that it is confirmed. Type 2 is that the cytology is equivocal or negative, and this is very commonly what we see in practice, that this may not come as positive. Then you actually based your this on the MRI findings, whether there are linear or nodular or both disease patterns which are seen in MRI. And this should be associated with typical signs and symptoms. Then you could say that this patient has probable metastasis. So probable is when the CSF comes negative, but you have unequivocal MRI findings which say that this is leptomeningeal mets. The last is when you don't have MRI findings are normal. These are normal, but you have typical clinical signs, and you have some features where your CSF you cannot put the patient as tuberculosis, cannot put the patient in infection, and that is the time you would see that possibly the patient has leptomeningeal metastasis. In clinical practice, you would these are the patients you would treat. This is a gray zone area whether you want to treat or you don't want to treat. Now, what are these MRI features which I was been talking about, and where do you look at them? A good site to look at them is at the cerebellum. Cerebellum. You could see that this folial patterns, you could see that there are here, here. You could see, is it visible? Yeah, you would see that these are enhancements here, and you know that this patient has leptomeningeal metastasis. Now the question comes that who develops leptomeningeal myths? And this is data from Tata Memorial Hospital itself. First of all, we understand that once patient develops leptomeningeal myths, actually has a grave prognosis. And in our database itself, the median OS was only around 2 months, 61 days. Now, who develops in lung cancer? Patients who have brain carinapegal mets, patients who have EGFR mutated, they are the ones who are likely to develop this. And this is a competing risk analysis which was done. What it shows is this is the incidence of leptomeningeal mets, and as you see, it keeps on increasing slowly. This graph, if I would have cut it at 40, you would have seen this line steadily going up. But this is the incidence of competing events. Competing events mean those events which, if they occur, they don't allow leptomeningeal metastasis to develop, which obviously in the case of lung cancer is death. So if the patient dies, they cannot have leptomeningeal mets in the future. And this is the graph which shows that the outcome of this patient is not good. It's around median is around 60. Let's come to the factors which we had seen in our patients. And what we saw in our patients, at least in Tata, is that patients who have driver mutation status, they had higher chances. Patients who had already had brain mets, they are the patients who had higher chances. Now, though this data shows that the median survival is only of 61 days, this data you must remember is of 4 randomized studies which were done in an era of 2010 to 2015-16, when second and third generation TKIs were not there, or they were too costly for these patients to afford. And hence, most of these patients had not been exposed to this second and third generation TKI. And hence, that is what the outcome you would get if you are not able to expose these patients. So, what is the goal of the treatment? We must understand that the survivals are dismal. Neurological deficits, once if develops because of leptomeningeal mets, usually is fixed and very rarely improves. This is not like brain mets, where you would have mets. Because of mets there is a neurological deficit, and from the mets you have a edema, and that edema gives rise to the additional deficit. Once you remove the mets, the edema would resolve, and that amount of neurological deficit could actually recover. Leptomeningeal disease, that doesn't happen. Most of the things are fixed and they rarely improve with therapeutic aid. So your goal is here to prolong the survival and maintain the quality of life, and that is you're trying to delay further neurological deteriorations in these patients. Now, what do? The first thing, whichever comes to any one of our minds, is to give intrathecal therapy in these patients. And let's look at the agents which we have for giving intrathecal therapy. Methotrexate, the most common agent, which half-life with CSF is at 8 hours. And this is a classical schedule where you could anywhere between 10 to 15 mg. Tata we use 12.5 mg. Twice weekly for first 4 weeks, once weekly for the next 4 weeks, and then once in a month. Sometimes they understand methotrexate. Those who have done ALL will also know that even if you do intrathecal methotrexate, it does get absorbed systemic circulation, and the chances that there is a chances that the CBC may drop, and in that case you may have to use polinic acid rescue in these patients. Cytarabine is another such agent. Half-life is less than 1 hour, so actually it's good. The half-life, it gets washed off fast. The schedule is again similar: 10 mg to dose twice weekly for the first 4 weeks, once weekly for the next 4 weeks, and then once in a month. There's also a schedule of liposomal cytarabine, which is good in the sense that if you see here, the frequency of injections comes down drastically. If it was for the first month, you would have got 8 injections, in which in this, if you use liposomal, you will get only 2 intrathecal injections. Now, normally we may say that what's the issue about it? It's an issue. If you treat patient with leptomeningeal metastasis, you will know that after third or fourth injection, the injections are painful. Many a times in our settings, the neurosurgeons don't agree to put a OMI reservoir in these patients, and in such situation, giving repeated intrathecal injections becomes a pain both logistically and both for the patient also. In that situation, liposomal cytarabine seems to be a better option. Now the question comes is, okay, we have a traditional thought in medical oncology teaching and even in oncology teaching that leptomeningeal meds, intrathecal therapy needs to be given. The question is intrathecal therapy helpful? And let's look at the study, and this came in breast cancer, in which the question was actually whether this such intraventricular chemotherapies are helpful or not. The publication actually came in 2004. It actually suggested, surprisingly though, that intrathecal therapy is not very useful. This is another study which has come in 2020, and it's with liposomal cytarabine, and it has come again in breast cancer. Now let's have a look at the results of the study. The primary endpoint for the study was leptomeningeal progression-free survival. For that, it did show that giving liposomal cytarabine led to an improvement in outcomes. 2.2 became 3.8. But for OS and for PFS, there was not much improvement with addition of this agent. This is touted as a positive study and got published in NeuroOnc, but it actually shows you that giving leptomeningeal injections, leptomeningeal PFS might improve, but definitely there's no improvement in overall survival. Unfortunately, none of the studies which have been there, very few studies, only 4 to 5 randomized studies have been done in this space. So none of them have actually taken quality of life. So I cannot tell you exactly whether there was an improvement in quality of life or the deterioration in quality of life was slower in patient who took intrathecal therapy. Now, what do we have evidence in lung cancer? Lung cancer, unfortunately, we don't have any randomized study which has been done in this space. This data, and this is from China, and which actually shows that there is no benefit of giving intrathecal um, chemotherapy for overall survival. But this was a study in which a lot of patients also received third generation TKI in this situation. Now, still there is no data basically in lung to either support to give it or not to give it, but going by the tradition we decide that okay, intrathecal, I'm going to give intrathecal. The question comes, which intrathecal would be better, whether it should be a single agent or combination to be given in this agents. And let's have a look at this data, where you would see that they had given intrathecal methotrexate, and in the other arm, methotrexate plus cytosine aluminoside. They did find that methotrexate was superior to the combined, but it was not much statistically significant, not much difference in the overall survival. What they did saw was those patients who responded to intrathecal therapy, they did better. So, which again means that combination is not very helpful. What about methotrexate when it gets compared with thiotepa? And what you see is that more or less they have similar efficacy in terms of the way they behave. Another study in which now cytarabine has been, this is the depot cytarabine which has been compared against methotrexate, not the convention like liposomal or a depot preparation was compared. And what it did show you is that if you see here, the median survival of the 105 days in the depot and 70 days in the methotrexate, which again suggests that if you give a depot preparation of cytarabine, it's majorly does a bit better than intrathecal methotrexate alone. And one of the reasons in this study was the frequency of intrathecal injections came down. And if you look at the depot preparation, you could see that the depot preparation was the 50 mg, which I told you, a single injection given 2 weekly was given. So it is much better with respect to compliance for the patient. There are other studies which have again tried to look at whether cytarabine is better or not. What had come consistently is if you are going to use the regular cytarabine, regular thiotepa, they're as good as methotrexate. If you're going to use the depot preparation of cytarabine, the evidence, at least in breast, majority patients with breast cancer, it does suggest that depot preparation of cytarabine would be slightly more better than the intrathecal methotrexate. But this evidence is with a group of patients which majority had a breast cancer patients and not lung cancer patients. Now the next question is, how do you give it? Whether you give it intrathecally via the way we give it in most of the situation, or you would like to use a Omaya reservoir. And it is that if you see, it, it does show that if you use Omaya reservoir, it is better for most of the patients if you're actually going to use methotrexate in this patient, because that enables a better distribution of the drug to happen. Now the issue is, at least in Tata, we have limited neurosurgery slots which have to be gone for glioma, also for Brainmets also. So this indication takes a backseat in that situation. But if someone has the facility, putting a Omaya reservoir seems to be a better option. Now, let's look at, we up till now discussed the classical ITs, methotrexate, thiotepa, cytarabine, and the liposomal cytarabine. Let's look at, do we have any novel ITs? And this was an interesting article that came from Dr. Kalitza. In fact, this is the investigator-initiated study, which was supported by Bristol Myers and Squibb. And this was done in 2017-18 time. And she actually wanted to see whether nivolumab intrathecally can be given, whether first is whether nivolumab intrathecally is safe, what is the dose you need to give, and along with this, she had also given systemic nivolumab. This was primarily done in metastatic melanoma patients, and so normally when you do such phase ones, we are clear that phase one is species specific. So we know that the dose, whichever she got, that can be used in other human species also. Whether that efficacy gets reflected or not, that needs another additional studies which needs to be done. What it did show was, when you see, she had used a dose of up to 20 mg, and that 20 mg came out to be the dose which you could give intrathecally from nivolumab, and the median OS, if you could see, was 46 weeks, which is much better than what I had been showing up till now. 46 weeks means nearly 11 months in this patient. But again, this is metastatic melanoma. This is not comparable to the data of breast and lung, which I've been showing you up till now. This is another phase 1 in which intrathecal trastuzumab was given in patients who are HER2 positive breast carcinomatous meningitis. And if you see here that they had administered 30 mg, 60 mg, 100 mg, and 150 mg dose. No DLT was observed in this patient, and hence the intrathecal dose they recommended was 150 mg. And it did show that a few of the patients, they develop, there's an ongoing phase 2, which will let us know whether intrathecal trastuzumab can be given routinely or not. But this is something, again, which you must be knowing about. Now, we all know that the newer TKI, they have a good CSF to plasma ratios. And let's have a look at what we can do if it's actually a lung cancer. And with the first, we'll talk about the first generation TKI and then go to the newer TKI. Whatever patient has leptomeningeal mets and you decide that I'll treat only with erlotinib, and this was actually answered in this study which got published in 2020 by Nokosuke. It actually showed that the objective cytological clearance was 30%, and the median time to progression was 2.2 months. Again, suggesting that if the patient doesn't have any exposure and if he is inaccessible to use the third generation TKI, giving erlotinib can actually clear in around 30% of the patients. Let's look at if we have to give osimertinib. We all know that osimertinib, the CSF to plasma ratio is actually more than 1. It's actually 2.3. It concentrates preferentially in the CSF than in the plasma. And if we are trying to do that, what would be the thing? So this was another phase 2, which again came in 2020. And you would see that this phase 2, as I was telling you, prior to 18 and 19, there are hardly any data coming up. In last 2-3 years, a lot amount of data has started coming in leptomeningeal field. And that was osimertinib in combination with bevacizumab. And let's see what results we got. You could see that the leptomeningeal PFS was 9.3 months. This was 12.6 months. Hardly any grade 3 or 4 adverse events was seen. And this chart swimmer's plot actually showed you that most of the patients had gone above 6 months as the progression-free survival. Again, suggesting that this is a good option to try in patients which have leptomeningeal mets, going osimertinib plus A. Bloom's study was another interesting study, and this is only osimertinib which has been given. And you could see here there are a few things, and let's look at this. This is leptomeningeal mets according to an independent review, and this is by investigators. And we'll look at these two things. The overall response rate, and this is where it differs. As investigators, you not only look at radiology, you also look at the symptomology of the patients. I'm not sure whether I have a slide on Ranu criteria for deciding what is the response rate, so I'll check if I have. That it actually takes not into account the imaging feature, it also takes into account the patient symptomology and also takes into account the steroid requirement of the patient, if the patient requires steroid. You could see that this was only 27%, but when you look at the radiology itself, it was around 62%. Again, showing that osimertinib alone also is not a bad option in this patient. Look at the median PFS, 8.6, 11 months. And if you go back and see, compared to that to the osimertinib plus bevacizumab study, more or less looks similar. Again, suggesting that if the patient can afford a single agent osimertinib, would be good enough. Now, we always have this habit of saying, okay, thankfully osimertinib has a better CSF to plasma ratio. What if you increase the dose of osimertinib to 160 mg? And this is particularly in patients who are T790M positive. And let's see what happens. Is the intracranial disease control rate increases? If you look at this, and if you could look at this is the Brainmets cohort, the overall response rate is 55%. In the leptomeningeal cohort, the complete response rate is 12.5%, but the intracranial disease control rate is around 92.5%. So again, suggesting that probably increasing the dose of osimertinib, if your patient can tolerate that, mainly most of the patients would have loss of appetite, or diarrhea. Most of the patient would have loss of appetite, diarrhea, or skin rash with an increasing dose of osimertinib, but that seems to be a good option in this patients. Let's look at this graphs, and these are very interesting graphs, and we will be focusing on this part of the graph. So if the patient has leptomeningeal cohort and T719 targeting has been done or not done, and you could see that what it says is the patient has leptomeningeal mets, T719 is positive or negative, and you are given 160 mg of osimertinib. What it shows is that the outcomes nearly remains similar. Irrespective of whether previous RT was given or not, the outcomes nearly similar. So, and this is one of the reasons why if you see that if the CRSF disease is there, even if the patient doesn't have T790M mutations, few of the medical oncologists will be tending to use osimertinib, but at a higher dose of 160 mg. Now, whether the TKI can be helpful or not, IT can be helpful or not when you're getting third generation TKIs, we don't know. This is a study which has been done at Tata Memorial Hospital, and few of you have seen the patients on this study. We have recruited 56 is the sample size, I suppose, and we have recruited 8 or 9 patients already. And this study, one arm the patient is going to get third generation TKI, and one arm the patient is getting a third generation TKI plus IT, and IT given is an IT MTX. And the primary endpoint here is not leptomeningeal PFS, but is the classical overall survival, so that there is no confusion on that. And probably this study should get over by next year and would give a definitive answer whether IT methotrexate is required or not when the patient receives third generation TKI. No topic nowadays and that's completed without any discussion on immunotherapy. And last few slides will talk on immunotherapy. And this is an interesting study. Actually, you could see that it actually came in Nature Medicine. This was a phase 2 study of pembrolizumab in patient with leptomeningeal carcinomatosis, and somehow most other studies of leptomeningeal are predominated by breast cancer disease and not by lung cancer disease, and that is, and you could see that to say that this is better, you required a OS 3-month OS of 43%. And let's look at what was seen in this study. You could see that the alive patients at 30 months, 3 months were 60%. If you look at the RANO response rate, which actually looks after the intrathecal response, hardly any CR or PR were there. Most of the patient had stable disease, and that was the best, and that was around 55%. In 20%, actually, it was not evaluable. So if you look at the evaluable population, this comes out to be around 60%. So what I'm trying to tell you is it's very difficult when you use RANO, which has radiological, clinical, and to get a response in RANO. You might get in RECIST, but not in RANO. The median OS was around 3.6 months. Hardly any conclusions can be given with this study. What it does show that when the patient has progressed in multiple lines and the PS is still better, you can still try pembrolizumab for the limited benefit it has in some patients in whom it can pull it across of around a year or so. Now, you would always see that, and that is what keeps immunotherapy of being interest, is you'd always see multiple case reports which coming that nivolumab was given, pembrolizumab given, and the patient had a sustained clinical CR, or 1 or 2 patient case reports you'll always see. And that is why many people are interested in seeing of how immunotherapy can be incorporated in the paradigm of leptomeningeal metastasis, especially in patients who are driver mutated negative. Now, this is a complicated chart which ESMO has made I don't like this chart, and hence I made a very simple chart which you, if you follow in clinics, it would be easier. Look at these poor risk factors, which is like poor performance status, significant neurological deficit, or this advanced systemic disease, and you actually don't have any good therapeutic option. It's best that you leave these patients alone. Do not do any leptomeningeal targeting or anything. They're best served by doing best supportive care. Patients who don't have any of these features, and these are the patients you would need to target extracranially also, and these were the patients you may consider doing intracranial management if the patient is not being targeted by a third generation TKI or the TKI which has a substantial penetration in CSF. So to conclude, leptomeningeal metastasis has dismal survival. In EGFR positive, you could give osimertinib 160 or with BEV. Pembrolizumab works. Intrathecal nivolumab works. Intrathecal liposomal cytarabine in breast cancer can be one of the options because the frequency of injections is less. It's better compliant with the patient and has shown to improve. If there are any questions, I'd like to take the questions. That's it from my side. Huh? Take a mic. Yeah. Is that working? Take that.
So in lung cancer and breast cancer, we see that those are the most common diseases leading up to brain metastasis. But some patients, they have solitary or multiple metastasis, but still no leptomeningeal involvement. So why is there a difference? And should we be evaluating patients who are diagnosed with parenchymal brain metastasis for leptomeningeal disease also at presentation with CSF exam?
So at present, what you do is now, if you see parenchymal metastasis, it's better that you pay attention to looking at the MRI, to the features which I told you. Whether you are seeing hypervascularity features, like more than one third is going, or enhancement at sites where the flolia are there, or enhancements inside the ependyma. If you see those features, then it's better to look for the CSF of the patients. It's important as clinician that we start looking at these features because traditionally the radiologist won't, many times, unfortunately, I've seen that they miss these features, uh, probably because of that the inherent thing that if it's brain mets that nothing much can be done for the patient, but at least in mutated patients, it's better that you look at these features which suggest that there are leptomeningeal metastasis is there or not. Because in such patients, giving a third generation agent becomes all the more important. Like for example, let's say that you had a solitary brain mets, so that oligomets, 2 or 3 lesions, but you have a leptomeningeal disease sitting over the cerebellum. The management changes. Now you are not going to ask the surgeons to do the surgery. You would actually go for a non-interventional with radiation, and you would think about doing uh, giving a third generation TKI for this patient, and or if you're not, probably doing the IT also with the patient for this patient. So that's the way management would change. So it's better that you keep an eye over leptomeningeal disease in these patients. Whether to do CSF in all patients at present is not recommended. Neither someone has studied that. But I suspect that this recommendation would come a few years down the line. And the reason being that the more or more TKL, now that we have reached third generation TKS, most of the TKS now focusing on higher brain penetrations. And this will be the time I'm sure we would be looking at what is the, not only for whether CSF is involved or not. If the CSF is involved, uh, what is the mutation pattern in the CSF? There are studies in brain mets which have shown that if you, uh, especially those who had solitary and oligo brain mets, when the surgery was done both in the lung and in the brain, 28% discordance is seen between the primary and the those which happens at the brain mets. And this discordance, we have limited studies, but theoretically speaking, if you use your logic, this discordance will be more when the patient progresses, because the kind of pressure, these mutations which I have extracranially, the same kind of pressure with respect to the pharmacokinetics is not there for the brain mets tumor. So your discordant would be higher, but there is limited data in that. So at present, to simply answer your question, no, you don't need to do CSF in all patients, but you definitely need to do an MRI in all patients of stage 4 lung cancer as it's recommended by the NCCN, and you need to learn to look at the MRI yourself to see whether there are any leptomeningeal features or not. And if you suspect any leptomeningeal features, then that's the time you would ask for an CSF. Yeah. Can you pass the mic, Jatin, back?
So, do the location of parenchymal lesion, like how close they are to the ventricle, have any association with the incidence of L1?
Not well studied, because this topic has rarely been studied, but it seems to be logical that if the disease is in the posterior fossa, as Dr. Prakash Shetty was also telling you, then the chances of hydrocephalus and spillover are more, but really not studied that if your frontal lesion, there would be more kind of leptomeningeal disease. If your lesions in the temporal lobe, you won't have, so this has not been studied. There's a question behind you.
The role of single agent bevacizumab in poor PS patient.
Okay. So per se for leptomeningeal disease, there is limited evidence which I am aware of. I'm actually not aware of any evidence which suggests that giving bevacizumab in patients with leptomeningeal disease helps. Saying that, there was a phase 2 which came in 2019 ASCO, which showed that patients who had brain metastasis, who were treated initially with local therapy where it was applicable, followed by systemic therapy, and when they had no other option of treatment left, in brain mets I'm talking, they were given bevacizumab, and they had quite a few of these patients did show response and had prolongation of outcomes with respect to the historical controls. So post second line in brain mets, it is one of the options which still exist. Now, whether the response seen in with bevacizumab was actually a true response or something in neuro-oncology which is called as a pseudo response, we don't know. Bev has a habit of rapidly decreasing the edema associated with brain mets, and that is difficult to interpret. Commonly gets interpreted as having a response to the lesion, but you would see that if you redo the MRI after a month or so, the solid tumor would start increasing. So yes, bevacizumab, second line and beyond, can be one of the options in patients with brain mets for which no systemic or no local options are remaining. Any other question? If there are any questions related to brain mets also, you can ask.
So theoretically, can we do CSF for EGFR or NGS?
Yeah. So the question is, can you do CSF for NGS? Yes, we do it in TMH. So if the patient shows only a cranial progression and leptomeningeal disease, we actually try to get a CSF cell cytology done, and this CSF cell cytology can then be subjected to NGS, and you could look at the mutation profiling also. See, you need to understand that the technology is advancing fast. Last masterclass, I was searching whether you could get a CFDNA with saliva also. I ended up not only getting articles from saliva, I ended up getting articles from sweat also. So you would get a time when, because CFDNAs are circulating everywhere, we will see that time in our lifetime in next 10 years where the technology will be so advanced that we may not have to pull a blood sample also. A sweat of the patient would be enough to diagnose which mutation the patient has. It's just a matter of development of technology. Any other question? If there are no questions, we have a pressing need to end this workshop because there's another workshop which needs to start at 12 o'clock. So I would say thank you to all for being here for the last 4 hours. And I would also like to know your feedback. Each time we used to have lectures of 10, 15 minutes, but there were complaints that we never got a comprehensive pictures to be shown, and that's why we had only 4 lectures this time, which went completely comprehensive on surgery, radiation, chemo, and leptomeningeal disease, so that we know that in the next lung cancer update, whichever the way you people prefer, we could do the workshop in that manner. With that, thanks all. Yeah.